pumped on the day? Yeah, it was a good day out there. The groomers were nice and fast this morning. I had about 5 centimetres of snow on them this afternoon. Tomorrow it's going to be snowy but cold, so please make sure you rug up for tomorrow. There should be some great conditions out there as well. For those still at the back, please feel free to keep grabbing some wine. We will have more sushi coming out in the foyer during our break today. So we're just going to try and disperse the line a little bit in the half-time sessions. So sushi will be in the foyer area after Sam's presentation, and the wine will still be in the back of this room. If anyone does have any questions, unsure about anything with the conference week, please make sure you check out the info book that we put together, or feel free to come see myself or Dylan. And we also have Delphine and Max from Locum Life out the front if anyone is yet to register. We do have some great photos submitted for our photo competition. So we're giving away some beanies, t-shirt, balaclavas, and a sushi maker. So definitely get excited for that one. If you're yet to submit your photos, definitely put them up there, hashtag EMS conferences for your chance to win big tomorrow. 2 presentations tonight, so let's get right into it and give a nice big applause for our first presenter, Sam.
All right, can everybody hear me okay up the back? Yeah, cool. All right, I promise I won't try and get too much crowd participation because I know everyone has beer and sushi to drink. So I'm having a bit of a chat on motorcycle trauma. Just for me, so I can get a bit of a gauge of who's in the room. Can I get everyone to put your hands up if you're a nurse? Cool. Doctors? Paramedics? Not related, but allied health? Couple in there. All right, we've got some doctors in there. Who works in retrieval medicine? Put your hands up, we've got a couple. Is anyone like a retrieval registrar? No, I've been told they want to study. Apparently, retrieval regs are the only creatures on the planet that can survive on caffeine and no sleep. So if you see any, let me know. We've got to catch them. All right, motorcycle trauma. So a little bit about me first. This is me. So I'm a critical care paramedic based in Far North Queensland. I've been in emergency services for about 15 years now and been working as a paramedic for about 9 of those. Pretty lucky to have gone to a few places in the world, seen some cool stuff, done some cool things. That little, let's see if I can make this little pointer thingy work. Over there. There we go. All right, so that's Townsville, which is where I work. Steve Irwin met a stingray about there. So just to give some context to where I do work. So on the left, we have our rescue helicopter, which is based in Townsville. I kind of moonlight between that and the single response car you see there on the right. On the left with the helicopter, who's from Melbourne? There's some Melbourne people here. Awesome, yeah. So that's the sun. We keep that up in Queensland most of the year. It's quite nice. It's awesome. So this is a look at Hinchinbrook, just north of Townsville. We can see we've got beautiful rolling hills, lovely greenery. It's really humid in summer, like it's disgusting. But the rest of the year, it's incredible. Recommend coming a visit. This is where Townsville's located. So we're about 1,000 k's north of Brisbane, which is about the same distance from here at the resort down to Tokyo or Osaka. Townsville's the only level 1 trauma centre outside of the southeast corner, which means that we feed a lot of patients into Townsville either by fixed wing RFDS or via the rescue helicopter. As well as road transfers for their care there. So we're talking about motorcycle trauma. I said I wasn't going to get too much crowd participation, but there's been hands up a lot already. Who here rides motorbikes? Awesome, that's cool. Who here has met a motorcycle patient or a motorcycle trauma patient? Yeah, cool. Everybody, awesome. All right. So most of the data I'm going to talk about today is Australian statistics, but there is some global stuff in there just to try and balance things out. In Australia, our motorcycles represent about 4.5% of all of our national vehicles that are registered in the country. And out of the 240 million kilometres travelled by Australian vehicles per year, motorcycles only cover about 1.4% of those kilometres. Having said that, for every kilometre you ride on a motorbike, you're about 30 times more likely to be killed versus somebody sitting in a car, which I think is pretty wild. And motorcycles account for, in Queensland, only 5% of our registrations, but they're representing, a fifth of our state road fatalities alone. And that kind of matches up with the Australian data, which says that riders and pillions represent about a quarter to 20% of our road traffic crash deaths. The remainder are all in cars. Given there's such a small percentage of vehicle registrations, they're massively overrepresented. As it turns out, about half of those crashes are involving another vehicle, and out of those crashes, the motorcycle is at fault about half the time as well. So what's a motorcycle? I feel like I need to discuss this because all of these are motorcycles except for the scooter. That is not a motorcycle, it's just masquerading as one. I joke, but it is important because when we're talking about global trauma data and we're looking at motorcycles, scooters are a whole other cohort of patients. Because they wear different PPE, they'll wear their helmet and normally their business suit. So the injuries that are suffered by scooter riders, also they're riding often more in metropolitan areas as opposed to regional. So there is a different injury profile to scooter patients. I can't talk about motorbikes without talking about mine. So this is Shinobi. She was built just down the road, just on her 10-year birthday, which is really exciting. The reason I bring this up is just to give some context to the forces involved in these patients. So my bike is not the fastest in the world, but she is the most pretty. And she'll go 0 to 100 in 3.1 seconds if I can hang on. It weighs about 192 kilos, full of fuel and oil, and it runs around about 101 kilowatts, which is about 135 horsepower on the move. This is not a fast bike. This is quick, it's not fast. For anyone that's ever seen those bikes cruising around Phillip Island, a BMW S1000RR from factory is running about 220 horsepower. They weigh about 170 kilos, which with a small Italian rider sitting on top of them, they have a power to weight ratio of almost 1-to-1, and they can do some incredible things like over 300 kilometers an hour, again, if you can hang on. A brief chat about starting, stopping and steering because this pertains to motorcycle crashes. So motorcycles are kind of unique is that everything kind of rolls off that front tyre. The initial turn in and stabilisation is from the front tyre, and that's from a contact patch less than the size of a tennis ball, which as you can imagine, if you come into a corner and there's some debris on the road, doesn't take much to upset the front end. Where the front end goes, the back follows, and the front end will go where you look. If you hammer the brakes really, really hard on a bike with ABS, normally things will stay level, but you do have the ability to do a stoppie. And when you take that stoppie, that back tyre comes off the road, and when it comes off the road, you lose any benefit from rear brakes altogether, which means that they will take longer to stop than a car. I probably should mention as well, I'll go back. Most bikes have a chain. I'll see if this wants to go backwards. It does not. We are only going forwards. Okay, we're only going forwards. Bikes have a chain, shaft drive, something like that to get power down to the back wheel from an engine. That's normally how they work. There are a couple of bikes with automatic gearboxes, but the majority you kind of click up and down with your foot. Different PPE that riders wear. There are full face helmets, open face helmets if you don't like your chin, and then modular helmets so you don't have to take your hat off at the service station. In Australia, helmets are mandated and you must wear them 100% of the time. Countries like the land of the free in the US, you don't have to wear a helmet in all states. We've got gloves as well, varying levels of protection from those. Most helmets have got this system nowadays, which is an emergency release for the layers inside the helmet. So if you find yourself having to remove the helmet from a motorcyclist, then I recommend you do it ASAP. You'll be able to pull these tabs inside a helmet, the whole lining comes out, and that just gives you more space to work to slide your hands in and help support the C-spine and head as you remove the helmet. Some more PPE, we've got these fully sick jeans which are lined with Kevlar. They do have a better slide resistance than normal denim, which is good for about 0.2 seconds, I think, at 60k an hour. It's really not good, don't wear jeans, wear denim with integrated Kevlar. And then you've got leathers on the right, which have got built-in slider pads. We've also got boots on the left, again, varying levels of boots. Depending on how much money you pay, dictates how much protection you get. But generally speaking, a full height race boot will provide a lot of support for your ankles and lower legs in the event of a crash. We've got some innovations coming through. The biker jacket on the right is cool, but as you can see, it provides very little coverage versus on the left where the modern MotoGP jackets have got built-in airbags with inertial sensors, which will actually pop up and help support your head, neck and shoulders. Brief chat on motorcycle crashes. So there's kind of two types that we'll talk about. One is the high side, which is the fellow on the left, who's enjoying getting airborne just before he hits the ground, and the person on the right who's done a low side, and I think a few of us have made a few of those crashes in the last couple of days already. And maybe it's just me. Now, this is a horrible crash which the video is not working for, unfortunately, but I recommend watching it unless it decides to work for me. Someone made a copyright claim apparently, and it worked last night, but not today. All right, cool. So no one dies in this crash. It looks bad. Everyone is okay. But I want you to watch it and just have a think about the forces involved and what injuries you might find on your patients. And don't forget to like, subscribe, and share. All right, so this is Phillip Island. We're coming down, I believe, Siberia turn 7, I think, coming into turn 8 and 9. Someone's had a low side crash. All is bad. They've been hit by a motorbike. Followed by more people falling off, followed by more people falling off. The rider on the left in the white, that's John McPhee. He's unconscious at the moment, but he'll be okay. Meanwhile, everyone else is sliding. The rider on the right, I believe he is actually a Japanese rider, but I'm not 100% sure, was doing really well until someone came around the corner, got target fixated, and unfortunately decided to run into him as well. He's fine. He walked away from this accident wild. The reason I show this, even though John McPhee's still unconscious, but he'll get better in a second, is this just shows the benefits of modern PPE on a motorcycle crash. This is John McPhee the day afterwards. He broke a bone in his wrist, and I believe he broke maybe a metatarsal, I think, and that's it. He was fine. MotoGP riders are very expensive to have off the track, so he was in surgery that night, getting whatever fractures he had plated, and was back on the bike within 48 hours. They're not allowed to have opiates in their system, so he was just riding it out, as you do. Still placed. Wild. Anyways. So who crashes? So we've got a nice little graph here, which is some older data, but it is Australian. Now it's from Canberra, so that's not our fault. But it does try and look at some trends which come across our motorcycle patients. Funny enough, normally young males tend to be overrepresented in crash data. No idea why, it just seems to happen. It's a coincidence. If we have a look at where that curve is though, we've got a sudden spike with our car occupants, which is the red, and that's around about that 18, give or take. That's where they tend to be getting killed. Our motorcyclists are a little bit later, around about 20. It's a bit more confidence, and licensing across the different states takes some time. The interesting thing is that as you get older in a car, you tend to die less often. So coming around to our 30-year-olds apparently is when you hit Captain Sensible levels, as a male that is. And you don't crash so much. Versus motorcyclists, there's that peak at 20, and then everything gets a bit better until your first midlife crisis around about 40, where we have a sudden spike in 40-year-old men normally buying motorbikes and aren't very good at riding them. But they get better. They get a bit better. They get some experience. They have some near misses. They probably will bin their bike at least once until they turn 50, second midlife crisis. More crashes. Some slides on the type of crashes that cause injury and cause death. So I mentioned before that the second vehicle is implicated in half of our Australian crashes. Out of those, 30% of the time it's the same direction, where the bike either gets hit from behind from the car, or the car hits, or bike hits the car from behind, one or the other. Someone re-runs somebody else, or merges across onto somebody else. Opposing directions, that's our head-on crashes. Only 20% of the time. Only seems to cause injury, probably more important here. Occasionally we've got adjacent directions, so turning across traffic or having an out of control crash, which as you can see is actually not very common. Versus our single vehicle injury crashes where it is a solo rider, we have got almost 50% as a result of a straight road crash where someone is out of control doing either something stupid or was doing something really cool and it's gone really wrong. The remainder, of course, are coming out of control around corners, and of course we have kangaroos, which causes about 10% of our single vehicle injury crashes with motorbikes. However, death is a little bit different. Head-ons with motorbikes, bad time. 39% death, no good, don't do it. And turning across intersections, adjacent directions, about 20% there as well. Versus single percent, we can see that misadventure is responsible for quite a few of those, either on a straight or curve. The curving roads at pace are normally a bit of a problem. I'll talk about the 4 stages of a motorcycle crash because it's cool knowing how things crash. First thing that happens is something goes wrong. I'm going to mention and manage the bias. So we say that speed kills, not true at all. We know that. I've done 300 k's an hour so far and I have not died even once. I've always been okay. But when you crash, different problem. Crashes happen for lots of reasons, and it's not necessarily because the rider has lost control because they had a misadventure or couldn't quite work out their capability versus their expectation. Medical crashes happen on bikes as well. Is your patient having a stroke? Have they had a seizure? Are they having a hypo? All of these things. Did their ego get so big that it swelled inside their helmet and they fell off? Lots of medical events happen with motorcyclists. We get things called target fixation. Has anybody in the room had target fixation this last 2 or 3 days where you've seen something and gone, oh no, oh no, oh no, oh no? Yeah. And I'm not talking about the line at the bar, I'm talking about other stuff. So motorcycles go where you look. This is why that you may see or hear about motorcycle crashes and you will see a beautiful, open, freshly ploughed paddock, which is nice and soft and dirt, and there is one tree, and that motorbike has hit that one tree. Because they've done exactly that. They've looked at the tree and gone, oh no, oh no, oh no, into the tree. Mechanical failure happens as well. If you lose your chain, you're going to have a bad time. Road conditions, if you lose your front tyre, you're going to have a bad time. And if you've hit another vehicle, you're also going to have a bad time. I mentioned alcohol and drugs because in Australia, drink driving seems to be a national sport, but we're getting better at it. We're dying less often on motorbikes. But is your patient under the influence of drugs or alcohol? Is that why they're ALOC? Worth thinking. Here's stage 2. So there's the flight and the fall. So this is normally a problem with high side collisions. There may be an impact with the rider hitting another vehicle. The fall may be many metres above ground. So we traditionally think about our motorcycle riders as they've had their slide into a parked something or other. We often forget that these patients, which are often very sick trauma patients, have had a fall from height of potentially 2 to 3 metres, and they may have gone over objects, over cars, over bonnets, and landed on the ground, breaking many things, followed by their slide, which comes later, which is our slide. So abrasion injuries are super common. This is where you get your big gravel rash. Gear will save your tail. And as you saw from those riders in MotoGP, they were crashing at over 150 k's an hour. They slid just fine. They did break a few bones, but that happens. But they didn't get any gravel rash. Their skin was perfectly intact and everything was wonderful. Followed by the final part of the crash, which is the sudden stop. So you get a rapid deceleration, and depending on how fast you go will dictate what happens to your poor internals when you come to a sudden screeching halt against your will. The other issue is not just the initial stop. It's if you have a sudden stop into, for example, the back of the parked car, and then the car behind you hits you as well. Or traffic turning, those sorts of things. A motorcyclist on the ground is very, very vulnerable. Has anybody read a book about dragons and dragon riders recently? There seems to be some popular ones. There's a saying that a dragon rider, once separated from their dragon, is vulnerable on the ground. Think of your motorcyclists as dragon riders. It sounds cool. Because when they're on the road, no one can see them, no one's paying attention, everyone's busy texting, and no one's any good at texting and driving. Immediate first aid may be life-saving. We're talking about basics here, opening airways. Now, who's been to the scene of a motorcycle crash before? Either by choice or by yourself? Yep, cool. So this is often what I find when I rock up to a scene of an accident. There'll be a motorcycle, or in this case a scooter or whatever that is. Someone's weird. What's important about this though is that number one, there are concerned bystanders, which is generally the case because either someone's hit them and they feel bad, and I appreciate that, or someone's called an ambulance, which again, I appreciate that as well. But both of these riders you'll see have got their helmets on, and people are naturally very reluctant to take their helmet off, and totally get it. But this is something which needs to happen very early in the piece. You'll also notice in our picture on the left, we have a police car doing a wonderful job of fending off something. But the picture on the right, our rider's still in the middle of the road, so they're very vulnerable to traffic coming around that doesn't see them. We've got a couple of priorities if we rock up at a motorcycle accident, either by choice or by ourselves. And one of those is parking. So if you see a motorcycle crash happen in front of you, hopefully you didn't hit them. If you did, have a chat to me later. Well, you can buy me a beer or something like that. I'll feel better for it. But parking your car or ambulance or whatever in a position where you can stop other cars from running over your rider again, that's really, really valuable. And giving some kind of sit rep, which may be either via radio for our paramedics to tell comms, hey, yep, really a motorcycle accident, or via calling the ambulance service in whichever country you're in just to let them know what's happened. I've said relocate rider if required. So we get really concerned about C-spine and moving trauma patients, and I think that's absolutely appropriate. But there may be times where your rider is located in such a dangerous position where that you must move them because their risk of getting run over by another car or truck is really, really high. We also have this thing in Queensland, I mentioned the sun before. It heats up our roads quite remarkably, where surface temperatures of our bitumen can be exceeding 50 or 60 degrees Celsius. So your motorcyclist who is being told to stay very still by the ambulance service on the phone, that's fine, but they're cooking on the road, so you need to move them off the road. A cool way to do that, if they're wearing gear, you can just grab their leathers, that will splint most of their injuries, and if you need to, just drag them off, support their head as best as you can. A cool thing to do as well is count your number of riders and count your number of bikes. Because if you've got more bikes than you have riders, then you're missing a patient and you're going to have to try and find them at some point on your scene. Priorities. So this is about getting to know your patient, and I mean really getting to know your patient. Motorcyclists often represent such a sick cohort of patients and we don't necessarily see them very often. But I'm a big believer in that I don't like surprises, and if you get to know your patient really well during your assessment, you shouldn't have too many surprises. You should be able to anticipate what's going to happen. You need to expose your patient. That means getting the helmet off as soon as you can. I mentioned before, pulling those little cheek pads, get them out, get that helmet off so your patient can breathe. I also said remove all clothing, and that means everything. Get them off, they've got to be naked. The easiest way to cut leathers off, they say cut along the seams. It's not good advice. Most leathers are triple stitched and are glued with various layers. If you just cut next to them, just follow the seams with your scissors. That'll help you get through them. And beware of injuries hidden by gear, which is self-explanatory. Don't stick your shears where their femur fractures sticking out because it'll hurt. The other thing we need to do is really try and keep these patients warm, and we've got a wonderful presentation coming after mine which will talk about ATC, but we want our trauma patient to be kept as toasty as possible without being too hot. So try and keep them warm as soon as you've exposed them, cover them back up again. Step 3 is going to be assessment and analgesia. So we're doing that really thorough head to toe, having a look for everything and anything, making sure we check the back as well when we're going to roll our patient, ideally only rolling them once. We want to assess all of our vital signs. That includes the temperature, includes the blood glucose, and if you're in an ED setting, grab a gas. See what you can find out. Now, I mentioned to some people I've delivered this talk to before, have a look at your vital signs, but then ignore them. It's not necessarily the case. It's more a case of saying, hey, look, we need to work out what our patient's doing right now, bearing in mind that our trauma patients don't always follow the textbook, which is a bit frustrating for me because it'd be nice if they just played the game, but they don't. We need to get some access. So if you can get a large bore cannula, then get a large bore cannula. If you can get 16s in forearms, ideally, not ACFs, because you bend their arm and it cuts it off and it's all awkward. If you can get them in, awesome. But if you can't get large bore access, then any access is good access. Bearing in mind, if you're placing IOs, you may have fractures in the bones that you're trying to put your needles into. So again, make sure you assess your patient before you start drilling. Gather a bit of a history. Everyone in ED loves to know how fast your patient was crashing. And as much as it's partly trauma junkie going, he was doing 200 k's an hour and he's alive, there are some important risk factors that we kind of mentioned in terms of our major trauma triage guidelines with patient injuries and their speed. So in Queensland, for example, any patients with a motorcycle crash over 30 k's an hour are considered to be a high risk in our trauma assessments. And anticipate injuries. So if we find that our patient has had, for example, a wonderful high side where they've crashed into a car, gone over the car and landed on the car, it's nice to be able to have a bit of an idea in our head of what's going to be broken and what we can start to do to start fixing that. Briefly touching on treatment and transport while I check my time, I think we're doing okay. So addressing our ABC issues. So if they're bleeding, we want to stop that. If they're in cardiac arrest, we want to stop that and have them unarrested if we can. Analgesia, splinting, packaging. So lots of broken bones are painful. We're going to have to move these patients. So trying to get on top of their analgesia nice and early is really, really important with motorcyclists, especially as you're about to pick them up off the ground and load them into an ambulance and then bounce them down the road 20 minutes. Or alternatively, if you're in the ED where you're going to have to log roll them at least once, they're going to need a CT with a probable head-to-toe pan scan at some point in time. There's going to be IDSCs getting placed. This is a painful experience. So trying to get on top of that nice and early and keeping on top of it is really, really important. If you're in a regional area or in metro and you have the availability of critical care and sometimes in some services doctors as well, consider getting them either to meet you on scene or rendezvousing on the way to hospital. As I mentioned before, these patients can be really, really unwell and can really benefit sometimes from pre-hospital care provided by critical care or physician services. This translates, I suppose, to in-hospital as well. If you get pre-notified about this patient coming in via ambulance, or if they just rock up on the back of the ute, to start making phone calls to your various specialties and going, hey, trauma team leaders, just letting you know, we're about to have someone come downstairs. They're going to be pretty sick. Let's just get the system ready to go. I've said consider area medical support. So again, where I work in Townsville, it's a regional hub and it's a level 1 trauma centre. If you're outside of that catchment, trying to get these patients moving towards, I suppose, a level 1 or the highest care you can nice and early is really important. And particularly with area medical support, with my system and most other systems, it does take a little bit of time for those wheels to start turning. So the sooner you can jump on the radio, phone, or whatever it may be for those working pre-hospital and start that system moving, the better. And then transport, of course, to an appropriate trauma facility. So we want to try and avoid those secondary transfers and retrievals if we can. Ideally, we get the right patient to the right hospital as fast as we possibly can, making sure that we still treat this patient on the way. You keep saying shock. So our patients are always in shock, and the bystanders are always in shock. Whenever we get a 000 call, it's everyone's in shock. What kind of shock? We need to find out their shock. Emotional distress? Yes. Emotional distress for me? Probably. But lots of other types of shock as well. So this is American data. This looks at motocross and motorcycle injury patterns. Now I mentioned this is the land of the free, so head injuries are probably overrepresented. However, the data pattern still fits. Extremity fractures, 30% of the time, they are super common. Now, various data sets, there's a lot of heterogeneity in the motorcycle data crash literature, I suppose. Where depending on who recorded it, sometimes AIS and ISS is or isn't recorded. Sometimes upper or lower limb injuries aren't differentiated, it just counts as an extremity fracture. But the vast majority of those patients that have crashed a motorbike will have some kind of extremity fracture, upper or lower limb. Lower limb seems to be more common. We're talking about spinal injuries here. Now this is not spinal cord injuries, this is spinal injuries, as into our spine itself, the bone bits. Super common with motorcyclists as well. The poor thoracic spine cops an absolute pounding when you smash yourself on the back at 80 k's an hour. So it's very common to get, transverse process fractures and stuff like that. Head injuries, so helmets do help, but a concussion is still a concussion. And again, this data is a broad sweeping, do they have a head injury? Yes or no. This does not discuss severity, this particular piece, until you move down to AIS, that is. But head injuries, super common. Chest injuries, super common. Everyone does ribs, it seems to be a thing. Having a look at our focused examinations and the rapidly disappearing focused examinations, there we go. So getting to know your patient when you assess them, I like to start at the top and I work myself down. That way I don't miss anything. But if you have a better system which works for you, that means you don't miss stuff, do that. So briefly bouncing back to head injuries. So beware of your agitated trauma patient. They're agitated for a couple of reasons, one of them being a TBI, which you may have to start managing, or it may be because they're just absolutely profoundly in hypovolemic shock and they get into that trying to die on you stage. Having a chat about head injuries, so just because their skull looks okay on the outside doesn't mean there's no internal injuries. We know that diffuse axonal injury is a problem with sudden deceleration from motorcycle crashes, and they may have a very varied GCS. So the initial assessment of that GCS when you get to know your patient is super important. If you can get a motor score, that's golden. We know that those TBI symptoms may take some time to manifest, particularly with subdurals and those sorts of things. So keeping an eye on your patient is really, really important. And if you've got Cushing's, that's a pretty late sign. We know that helmet damage has poor correlation with injuries, so we always will try and, as an EMS service, bring our patient's helmet with us to hospital. It's nice to look at, but if the helmet's been demolished, it kind of says they're probably going to be sick, doesn't always mean they're going to be sick. We don't know what their helmet was like before they bit into their bike. However, helmet type does have a correlation with their injury, and as I mentioned before, open face helmets, not a great time. Wear a full face helmet if you're going to crash your motorbike. big impact to their head where they've had apnea. Briefly looking at the C-spine, so we know that there's lots of shearing and compression and torsional forces exerted on their paw bones, and they may have a spinal cord injury. Between C3, C5 keeps the diaphragm alive. That's our respiratory arrest worry area. They may have some unusual and altered neurology, so you may find some of your spinal cord syndromes popping up when you first meet these patients, bearing in mind that they may resolve over time as well. Having said that, taking the time to reassure your patient that we're going to get some scans, that things may progress and things may get better and may get worse. I think that kind of reassurance is really important, especially when you're talking to young trauma patients that can't move their legs. It's terrifying, but it doesn't necessarily, of course, last that long. But if you have a poke on their spine and they've got crepitus or severe pain, that's a good thing to be worried about. Thoracic and lumbar injuries may be present, I mentioned that before, and the mechanism of their crash may mandate putting on a spinal collar. Now, we in Queensland have moved to soft collars. They are fantastic. I know that the rest of the world is catching up in different areas on that. But it may be worth tracking that collar on even if they haven't got SCI symptoms as a just in case. It's a good sort of precautionary red flag for people to see that and go, make sure we handle this with care. Looking at chest and lung injuries, I mentioned before rib fractures, chest injuries 25+% of the time. If you manage to break your first and second rib, that's associated with a big force, as it is with your sternum. Anticipate multiple rib fractures. Now, on palpation, I'm no good at picking up rib fractures. X-ray is much, much better than I am, but we know that rib fractures are really painful. I mentioned before getting on top of that analgesia nice and early. They've probably got a pneumothorax. That happens. Do we have to do anything about it? We'll talk about that in the next slide. But for the students among the room, every rib that we've got has got a vein and an artery and a nerve sitting in a bundle behind it, which means every time you break a rib, it's going to hurt and it's going to bleed. Expect a hemothorax for that reason. In our patients that are still spontaneously breathing, if they've got hypotension and we reckon they've got a pneumothorax and they're spontaneously breathing, making sure we work out which patient cohort is which, doesn't mean that they've got a tension pneumothorax we need to decompress. It probably just means that they're bleeding somewhere. We know that if we give patients with rib fractures some pain relief, we'll fix their SATs and we'll fix their tidal volumes because of that. So a brief look at a kind of a pneumothorax. We've got somewhat of ants marching along this ultrasound here, but not much. So we know that on a spontaneously breathing patient, we breathe in with a negative pressure in our chest, which is why it's less likely that your patient is going to be tensioning if they're spont breathing. If you're bagging that patient, you're providing positive pressure ventilation, different patient altogether. If that one starts dropping their blood pressure, really reconsider if you need to decompress them or not. The ICU studies that I've found have suggested that pre-hospital ambulance miss quite a lot of pneumothoraces, and in some cases tension pneumothoraces. However, there is a selection bias here, which is that they've made it to ICU for ICU to complain about. So do we need to do anything about it? Different question. If your patient's in respiratory distress, decompress their chest. If they're starting to become hypotensive and they're spontaneously breathing, and they're not in respiratory distress, you need to ask yourself, are they bleeding and where are they bleeding from? I'll briefly touch on tamponade and aortic trauma. So that rapid deceleration can cause really nasty shearing and rupture of the aorta, and that tends to happen around about the proximal descending aorta, just distal to where your left subclavian comes across. That's because the pericardium is going to move during the deceleration, whilst the aorta itself is going to remain fixed. That's where that tearing can happen. These patients, if they tear their aorta, they just die. If you're going to crack the chest on one of these people, look, I'm not working as a consultant, as a trauma specialist, so feel free to make your own assumptions on when you'd want to do this. But the general literature and guidelines that I would suggest is that if you're on scene with your patient and they've been pulseless for more than 10 minutes, then opening the chest is really going to offer very literal to no clinical value. And you're probably just doing a post-mortem, really. You won't be able to fix very much. Touching on abdominal injuries. So up in the top right, we have what I'm calling the handlebar sign, because I can't find another term for it. But this is where your patient, traditionally BMX riders normally, but motorcyclists as well, will crash their BMX or scooter nowadays, or motorcyclists, and get a handlebar in the tummy. Our liver runs across the entire, almost the center of our abdomen there. And it's very common to have a liver injury, and of course splenic injuries on the left. Super common to just demolish that thing if you hit it hard enough. Peritoneal innervation is really, really important. So anybody with abdominal bleeding, as soon as you start to innervate the nerves in your peritoneum, they can help mask a tachycardia. So if you're looking at your patient who is profoundly shocked, and I'm talking hypovolemic shock, with a heart rate of 80 and a blood pressure of 70, it's not necessarily because they're not hypovolemic. It may be because they've got blood in their belly, which is preventing them from mounting a tachycardia, or medications, of course. As I said, some people don't play by the rules. Yeah, aorta is out to ruin your day. We know about that one. You can scan most of it with an ultrasound for the paramedics in the room that don't normally do e-fast. You can see most of it, but not all of it. So there are parts of the aorta which you just won't be able to scan, bearing in mind that an injury there could be a real problem. I've said female patient, is she pregnant? Probably need to reword that. Is your patient bearing a child? Gender is irrelevant at the moment. The reason I mention this is because, number one, when we're talking about referral to a trauma hospital, we need to make sure that if our patient is pregnant, that we can go to a hospital which has appropriate facilities to receive that patient for the care that they're going to need down the stream. I mentioned e-fast. Have a squiz, see what you can find. Use it to help find the diagnosis. Don't necessarily use it to rule out stuff unless you're feeling particularly confident with your sonography skills. Briefly having a chat about our bowel and bladder injuries. So mesenteric injuries are super common with a very large force to the abdomen. And if they've got a sore belly, we know that it can indicate a bunch of stuff, including ruptured bladders and pelvic trauma and stuff like that. I mentioned before about stripping your patient. Having a look for any bleeding from the urethra or any bleeding from the bowels, really, really important, because it's going to help us identify potential pelvic fractures, bowel injuries, and bladder injuries as well. Again, having a look with an ultrasound will help you out here. This is a beautiful vascular photo of the pelvis for those that haven't seen it. It is highly vascular. So there was a saying in EMS years ago that you used to be able to, 2 litres was about the amount of volume that you'd hold in your pelvis, and that was kind of a nice number that we used to work with. Turns out, load of rubbish, and you can hold almost your entire blood volume in your pelvis if it is broken. So don't break your pelvis, because it's a bad time. Signs of fracture may be subtle. So we used to spring pelvises back in the day, which I can see a few doctors in the room shaking their heads. So we used to spring pelvises to see if they were broken or not. No bueno, don't do it anymore. But having a really good look at the pelvis from the outside with your hands and some gentle pressure to see if there's any pain, I think is okay, but being gentle. If it's not symmetrical, have a think about it. Is there a fracture or not? If they're unstable, as in hemodynamically unstable, make sure we chuck a pelvic binder on these people. If you think that there's a fracture, but they're not yet unstable, put a binder on these people. If everything is fine, get ready to put a binder on these people. Okay. A nice way to do this for the EMS folks in the room is that when you get your patient on the scoop or in your stretcher or whatever it may be, put a binder on the bed first at the right level, make sure it's at the right level, and then that way, if for some reason your patient does deteriorate during your trip to hospital, all you have to do is just tighten the binder on. So bones, more bones. So bones bleed, and our femur fracture, if you don't reduce it, there's a potential space there. You can hold over 1 litre of blood, almost up to 2, depending on how long your femur is. There's lots of arteries in that area as well. So we want to try and reduce these fractures. Number one, to help reduce the risk of further vascular injury and tissue disruption, fat embolism, all those sorts of things. But number two, because they really hurt. And amputation can be a problem with femurs. Now, I was going to put a cool trauma junkie photo in here, but I appreciate some of us are on holidays, so I've decided to leave it out. Suffice to say, if you've got an arterial hemorrhage, tourniquets on nice and early are super, super important. And as you'll hear in the next presentation, keeping your blood in your body is much more valuable than trying to add on products later on. Cool. And traumatic cardiac arrest. So if there's some subscribers to the TCCC, our Tactical Combat Casualty Care, I think that's about right. I'll briefly touch on traumatic cardiac arrest for our motorcyclists. There's lots of different acronyms which exist. I think they're all much of a muchness. I can go back. It does not want to go back.